Introduction. Health care data was never meant to become a weapon of immigration enforcement. In the complex web of American governance, two massive institutions, healthcare and immigration enforcement, have traditionally operated in silos. One exists to preserve and protect life, especially for the poor and vulnerable. The other exists to monitor, detain, and remove individuals deemed a threat to national immigration laws. But when these two systems collide, the result is not just policy confusion, it's a moral, legal, and humanitarian crisis. This is precisely what's happening as the U.S. Immigration and Customs Enforcement, ICE, gains unprecedented access to Medicaid records, a trove of sensitive information intended solely to provide health coverage for low-income residents, including children, elderly, and the disabled. In doing so, ICE is introducing a dangerous new precedent, turning public health infrastructure into a surveillance tool. The implications are enormous. While Medicaid has always had documentation requirements, the intent of the program was never enforcement, it was care. Yet by tapping into these records, ICE is reportedly able to locate, track, and eventually deport undocumented immigrants who may have enrolled in the program or whose children, often U.S. citizens, have. The result? A new wave of fear spreading across immigrant communities, especially among parents who now face the impossible choice between protecting their family's health and avoiding deportation. This article offers an in-depth investigation into this unfolding situation, drawing on policy documents, legal analyses, healthcare ethics, testimonies from immigrants and frontline healthcare workers, and expert perspectives. We will explore how ICE gains access to Medicaid data, what legal changes enabled this shift, the immediate and long-term consequences for immigrant families, the risks to public health and community trust, the constitutional and ethical dilemmas posed, possible paths forward for reform and resistance. The story is not just about a database or a bureaucratic maneuver, it is about what kind of country the United States is becoming. In a moment when immigration continues to polarize national politics and trust in institutions is deeply fractured, the weaponization of healthcare data reveals a deeper truth, that enforcement-first policies can bleed into every corner of civic life, even the doctor's office. Setting the stage, a nation divided by immigration. Since the earliest years of the American Republic, immigration has been both its lifeblood and battleground. From Ellis Island to the southern border wall, how the U.S. treats immigrants has always shaped its moral identity and political climate. But over the last decade particularly, under the Trump administration, immigration policy took a dramatic turn. The shift was from a system that, while imperfect, still offered some pathways to integration to one that prioritized detention and deportation at all costs. Initiatives like the zero-tolerance policy, child separation, and record-level ICE raids shocked not only immigrant communities, but even longtime observers of American politics. In this landscape, the effort to use Medicaid data for immigration enforcement is not an isolated act. It is part of a broader strategic realignment tone that seeks to make every institution, every service, every state agency complicit in the enforcement of immigration status. Medicaid, the lifeline for the poor and, now, a liability. Medicaid serves over 76 million Americans, including low-income families, pregnant women, children, people with disabilities, and the elderly. Funded jointly by federal and state governments, it is the cornerstone of public health for vulnerable populations. For immigrant communities, Medicaid has always been a tricky terrain. While undocumented immigrants are ineligible for full Medicaid, their U.S.-born children are not. Pregnant women may also qualify in emergency cases. The system was imperfect, but served as a healthcare buffer for those on society's margins. Now, however, that buffer has become a trap. By accessing information such as home addresses, contact details, family relationships, citizenship status, social security numbers when available. ICE can effectively track down individuals for arrest and removal even if the person enrolled in Medicaid is not the actual target, for instance, if the data reveals an undocumented parent's location through their citizen child's enrollment form. What sparked the alarm? In mid-2024, investigative reports from outlets such as The Washington Post, ProPublica, and CBS News began to uncover a disturbing trend. ICE had increased its use of administrative subpoenas and data matching protocols to identify individuals through Medicaid databases, especially in Republican-led states. While the exact mechanics vary by state, what emerged was a pattern. State Medicaid agencies were sharing data with federal authorities upon request. In some cases, data was voluntarily transferred. In others, ICE used legal reinterpretations of older immigration statutes to justify data access. Though the Department of Health and Human Services, HHS, claims that it still upholds privacy laws like HIPAA, loopholes particularly around national security and law enforcement necessity have been quietly exploited. Immigrant advocacy groups immediately sounded the alarm, arguing that the move would dissuade people from seeking medical help, punish U.S. citizens, children, for the status of their parents, undermine trust in the healthcare system, create a dangerous precedent of data abuse, a new kind of fear in the clinic. The consequences were immediate and chilling. Across immigrant-rich communities in California, Texas, New York, and Florida, doctors, nurses, and health administrators began reporting the same thing. Our immigrant patients stopped showing up, even for chemotherapy, even for prenatal care. Anonymous physician, Community Health Center, Houston. Mothers pulled their children from scheduled immunizations. Pregnant women delayed or skipped prenatal visits. Families refused to give updated addresses. Healthcare became a surveillance risk hand, the clinic a place to be feared, not healed. This fear is not irrational. For many immigrants, the memory of past ICE raids at schools, courthouses, and workplaces is still fresh. Now, with the infiltration of Medicaid, even healthcare spaisance considered sacrosanctare no longer safe. The bigger question: what happens when data becomes a weapon? This situation raises profound constitutional and ethical questions. Is it legal for the government to use health data for deportation? Does this violate the Fourth Amendment's protection against unreasonable searches? Is it ethical to risk public health to pursue immigration enforcement? What precedent does this set for other social programs, e.g., food stamps, housing assistance? We are no longer talking merely about immigration or health care. We are talking about data, sovereignty, civil rights, and the boundaries of government power in the digital age, a fork in the road. The United States now stands at a crossroads. The question is not whether immigration laws should be enforced. Reasonable people can disagree on the method and scope. The question is, should the enforcement of those laws come at the cost of public health, privacy, and human dignity? In the sections to come, we will dissect this issue from all angles: legal, political, human, and philosophical. We will examine how it happened, who it affects, and what can be done. Because at the heart of this story is not a database or a deportation order. At the heart of this story is a child with a fever, a mother with cancer, a father with diabetes, and a country deciding who deserves to be well and who does not. The legal and policy background: to understand how a public health system like Medicaid could become a tool for immigration enforcement, we must delve into the policy frameworks, statutory interpretations, and bureaucratic maneuvers that made such a transformation possible. This isn't a sudden shift. It is the culmination of decades of evolving immigration law, digital surveillance infrastructure, and political pressure to merge civil enforcement with administrative data systems, this section will explain the foundational structure of Medicaid, long-standing legal protections on health information, the interpretation of immigration law that enabled this shift, the growing digital footprint of immigrant families, federalism's role, states' autonomy and vulnerability, Medicaid, a public health program with federal roots and state administration. Medicaid, established in 1965 as part of President Lyndon B. Johnson's War on Poverty, is a means-tested program that provides health care coverage to low-income Americans. It is jointly funded by the federal government and individual states, but is administered at the state level, which leads to variations in eligibility, implementation, and data management. Key features of Medicaid: funded 50-83% by federal matching funds, depending on the state. Covers pregnant women, children, people with disabilities, and low-income adults. States have discretion to include or exclude specific categories, like lawfully present immigrants, after a 5-year wait. Emergency Medicaid is available for undocumented immigrants for urgent medical conditions. Crucially, when someone applies for Medicaid, they submit deeply personal information, names, addresses, employment status, family relationships, citizenship status, if applicable, and sometimes even Social Security numbers, SSNs. For years, this data was protected under HIPAA and state confidentiality laws. The goal was medical care not surveillance. Legal shield, HIPAA, and the promise of privacy. The Health Insurance Portability and Accountability Act, HIPAA, of 1996 is often regarded as the gold standard for protecting medical data in the U.S. Its privacy rule explicitly prohibits healthcare entities from disclosing personal health information, PHI, without patient consent, except in very narrow circumstances such as imminent harm to self or others, public health emergencies, judicial subpoenas or law enforcement warrants, but there are gray zones, particularly when data is requested by government agencies for administrative purposes, loopholes that ICE can exploit. Minimum necessary standard. Agencies can request only the minimal data needed for a stated purpose, but the law doesn't define that threshold clearly. De-identified data. Aggregated records stripped of personal identifiers may be used for secondary purposes, but re-identification is often possible. Law enforcement exception. If an agency claims it's conducting a lawful investigation, Hawaii PAA permits disclosures in some case, especially if accompanied by an administrative subpoena, which ICE can issue internally without a judge. These legal gaps offer ICE a path of least resistance to Medicaid data. The 1,996 laws that changed everything, IRERA and PROWORA. The modern framework for immigration enforcement stems from two pivotal laws passed in 1996, the Illegal Immigration Reform and Immigrant Responsibility Act, IIRRA. Expanded categories of deportable offenses, reduced judicial discretion in deportation cases, encouraged data sharing between agencies for immigration purposes, the Personal Responsibility and Work Opportunity Reconciliation Act, PRORA. Reformed welfare programs, adding strict eligibility rules for immigrants, created the public charge doctrine, penalizing immigrants who used public benefits, encouraged states to verify immigration status for Medicaid and food stamps. Together, these laws laid the groundwork for the infrastructure ICE now uses. Although they didn't explicitly authorize Medicaid data sharing, they blurred the lines between public welfare and immigration enforcement, creating a culture of suspicion around immigrant benefit use. The Trump administration's radical reinterpretation, while IRIRA and PROWORA were latent tools, it wasn't until the Trump administration that they were activated in a new, more aggressive way. Key shifts. Expansion of public charge rule, 2019. Immigrants who use Medicaid, food stamps, or housing subsidies could be denied green cards. Even legal immigrants avoided benefits out of fear a chilling effect. Surge in ICE, subpoenas, and warrants. ICE increased use of administrative subpoenas, Form 19, G639, etc., to request data from hospitals and Medicaid offices. These are not issued by courts, but are often honored by compliance officers unsure of their authority to resist co-opting state databases. In Texas and Florida, ICE partnered with state health departments to access insurance verification databases, claiming to be checking for fraud. Once inside, ICE could cross-reference addresses and identifiers to locate undocumented persons. Under Trump, the priority was maximum deterrence, a strategy aimed not just at deporting people, but at scaring others into self-deporting or disappearing from public systems. A perfect storm. Digital bureaucracy meets enforcement mandate. The early 2000s brought digitization of Medicaid records, the rise of electronic health records, EHRs, and interoperable databases for cross-agency analytics. What began as a health modernization initiative became a surveillance opportunity. Today, many state Medicaid systems are linked with driver's license bureaus, connected to SNAP and TANF databases, synced with vital records, birth, death, hosted on third-party platforms with minimal public oversight. This massive data lake makes it easy for ICE to use data analytics to find suspicious patterns, e.g., multiple addresses, large households, locate individuals via address, updates, or contact phone numbers, determine if undocumented immigrants listed themselves as guardians of citizen children, common on CHIP and Medicaid forms. The irony? A system built to make healthcare efficient is now being repurposed to make deportations efficient. Federalism in flux. States as gatekeepers or collaborators. Because Medicaid is administered at the state level, each state decides how to store its Medicaid records, whether to honor ICE data requests, what privacy protections to uphold. This creates a patchwork of policies across the nation. Cooperative states. Texas, Florida, Georgia often comply with ICE requests, citing law enforcement cooperation. Arizona, Alabama have passed legislation supporting cross-agency data sharing. Protective states. California, New York, Oregon limit cooperation with ICE, citing constitutional privacy rights. Illinois bars sharing of health data with federal enforcement agencies without court order. The result? 2 Americas for immigrants. In one, accessing Medicaid could mean medical care. In the other, it could mean a knock on the door at dawn. State-level resistance. Lawsuits and legislative shields. In response to ICE's expanding reach, some states and advocacy groups have filed lawsuits challenging the legality of administrative subpoenas, passed sanctuary health laws to protect patient information, encouraged hospitals and clinics to adopt don't ask, don't share policies, called on Congress to amend HIPAA and Medicaid statutes to clarify privacy limits, yet the legal terrain remains murky. Courts are divided on whether ICE's subpoenas are enforceable without a judge's approval. Meanwhile, many compliance officers in overburdened Medicaid offices err on the side of cooperation rather than risk legal liability. A dangerous precedent. What happens when Medicaid becomes a tool of ICE? It's not just a health policy story. It sets the stage for other programs to follow. SNAP, food stamps. Data on children's school lunch eligibility can reveal family status. Public housing. Residency records may contain undocumented individuals. Unemployment insurance. Work history and income reporting can be cross-matched with immigration databases. This is the slow creep of total state surveillance, where every government service becomes a possible threat for those without proper documents. It's a world where health, food, shelter, and survival itself become conditional not on need, but on citizenship. How ICE gains access to Medicaid records. The fusion of health data systems with immigration enforcement is no accident. It is the result of a calculated strategy and a series of legal and technological steps that allow ICE to bypass traditional checks and balances. While the public may assume that health records are protected behind layers of federal laws and doctor-patient confidentiality, the reality is more troubling. In this section, we will analyze the exact mechanisms through which ICE accesses Medicaid data, how administrative subpoenas are used as legal workarounds, the role of data brokers, state databases, and interagency cooperation, case studies from states like Texas and Florida, why hospitals and Medicaid offices often comply willingly or under pressure, the anatomy of a data request, from ICE to Medicaid. ICE has multiple tools at its disposal to obtain information related to immigrant identity, address, and presence in the country. These tools often bypass judicial scrutiny and exploit bureaucratic vulnerabilities. Here's how a typical data request process might look. Target identification. ICE identifies a person of interest through tips, biometric scans, or prior detentions. Database cross-matching. The agency runs a scan across multiple databases, state driver's licenses, prior arrests, visa records, or even school enrollment. Medicaid linkage. If Medicaid usage is suspected, e.g., through an emergency Medicaid claim or a CHIP enrollment for a child, ICE issues a request to the state Medicaid office. Form I-9 subpoena or G-639 FOIA request. ICE sends an administrative subpoena requesting specific data fields such as name, address, phone number, household members, or identifying documents. Compliance. State officials or healthcare data managers lacking clear legal mandates to deny often comply, forwarding the requested records. Unlike a judicial subpoena, administrative subpoenas do not require a judge's signature or probable cause. ICE agents can generate them internally, and in many cases, agencies respond within days. Administrative subpoenas. A loophole in due process. Under Section 235 of the Immigration and Nationality Act, ICE can issue subpoenas to obtain records relevant to immigration enforcement. These are not the same as court-ordered subpoenas. They are self-issued, meaning ICE essentially polices its own use of them. This tool, once reserved for fraud investigations, is now used far more broadly. Why it's problematic? No judicial oversight. There is no independent arbiter evaluating necessity or legality. Confusion at the state level. Many compliance officers don't know they can legally contest or reject these requests. Speed and silence. There is no requirement to inform the individual whose data is being requested. This administrative mechanism has become ICE's secret key-opening access to not just Medicaid data, but potentially to hospital billing records, insurance enrollment logs, and public clinic databases. Data brokers and private contractors. The hidden infrastructure. Behind every state-run Medicaid system lies a network of third-party vendors, IT contractors, and data clearinghouses. These actors manage enrollment portals, claims databases, and real-time eligibility verification systems. In some states, ICE doesn't need to go through the Medicaid office directly. Instead, it may subpoena a vendor, e.g., Maximus, Deloitte, Accenture, managing Medicaid's digital infrastructure, use E-Verify and SAVE, systematic alien verification for entitlements, databases to flag mismatches, purchase access to data brokers who aggregate anonymized but re-identifiable data sets. Example: in Florida, ICE reportedly used a Medicaid vendor's back-end database to match addresses of CHIP-enrolled children with parents suspected of overstaying visas. Because these vendors are private, they fall into a legal gray area. They are not fully bound by HIPAA in the same way that hospitals are. This leaves an open flank for ICE to target. State-level cooperation. The case of Texas. Texas has become ground zero for Medicaid data access by ICE. The state participates fully in SAVE and E-Verify systems, has no laws prohibiting information sharing with immigration enforcement, cooperates with ICE under the justification of fraud prevention. A 2023 investigative report by the Texas Tribune revealed that state Medicaid staff had responded to over 1,200 ICE requests for records in a single year. Often, these requests pertain not to Medicaid recipients themselves, but to others listed on the forms, including guardians, parents, or emergency contacts. Example: a 9-year-old U.S. citizen receives Medicaid. Her undocumented mother is listed as the emergency contact. ICE issues a subpoena for the child's file. The mother's address and contact information are extracted and used to locate her. In some cases, ICE later denied targeting individuals through children's records, but evidence suggests otherwise. Fear, confusion, and compliance. Why states give in. Why do state Medicaid offices comply so readily? Lack of training. Many employees are unfamiliar with the legal limits of data sharing. Ambiguous laws. HIPAA and immigration laws don't explicitly say you must refuse. ICE requests without a warrant. Political pressure. Republican-led states may view ICE cooperation as a duty, not a violation. Risk avoidance. Agencies fear legal repercussions if they are later accused of obstructing enforcement. In the absence of federal clarity, most state agencies choose to err on the side of cooperation even when ethical and constitutional questions abound. Human collateral. How ICE uses Medicaid to build deportation cases. Once ICE secures access to data, they don't always act immediately. Instead, they may monitor updates to contact info or addresses, build broader family profiles, linking multiple individuals, cross-match with DHS or DOJ databases, stage raids timed with hospital visits or appointments. There are growing reports of ICE arrests in hospital parking lots after Medicaid appointments, during home visits where a Medicaid recipient lives with an undocumented person, at pharmacies or urgent care clinics. One nurse in New Jersey recounted, a mother brought her asthmatic child in. She was trembling, kept checking the door. After we treated the boy, she disappeared and never came back. A week later, we learned ICE had visited the clinic asking for her. This is data-enabled immigration policing, and Medicaid is the entry point. The role of CHIP, Children's Health Insurance Program. Another key entry point for ICE is CHIP, a Medicaid-adjacent program providing low-cost insurance to children in working-class families. Many CHIP applications list parents' names, phone numbers, home addresses, immigration status, if requested by the state. Even when parents are undocumented but children are citizens, the parents are legally allowed to apply on their children's behalf. However, once this information is recorded in the state's CHIP database, it becomes vulnerable to ICE requests. In 2022, a group of Texas advocates sued the state health department after reports surfaced that ICE agents had used CHIP application data to conduct silent arrests, raids with no warning or warrant, based entirely on administrative subpoenas. No requirement to notify families. Perhaps the most disturbing aspect of this process is that immigrants are rarely notified when their data is accessed or shared. There is no mandated notification by Medicaid offices no public record of ICE subpoenas issued, no requirement that health facilities inform patients of ICE requests. This leaves families blind to the surveillance, often until it's too late. A knock at the door, a child waiting at school with no parent to pick them up, a clinic calling for a follow-up and finding the number disconnected. These are the quiet consequences of invisible enforcement. Attempts at digital safeguards and why they fail. Some states have attempted to build digital walls between Medicaid data and external access. Examples: California implemented encryption and access restrictions. New York limited staff roles who can handle ICE inquiries. Oregon passed a data sharing protection law in 2021. But technical solutions are no match for political pressure, federal threats of funding cuts, or lack of clarity in HIPAA interpretations. ICE does not need to break encryption, they just need a willing clerk and a vague legal pretext. Summary: the pipeline from healthcare to deportation. The mechanics are clear, if chilling. A child or pregnant woman applies for Medicaid, their application logs, address, and family info. ICE accesses the data through administrative or cooperative channels. ICE builds a profile and locates the target. Deportation proceeds sometimes quietly, sometimes violently. This is not a hypothetical risk. It is happening now in hospitals, homes, clinics, and schools. And as we will see in the next section, it is having a devastating effect not just on undocumented immigrants, but on the health of entire communities. Consequences for immigrant communities. Behind the legal mechanisms, bureaucratic justifications, and policy papers lies a much more visceral truth. The human cost of surveillance-driven enforcement is devastating. While ICE's access to Medicaid data may appear abstract or bureaucratic to outsiders, for immigrant families, especially undocumented parents and their U.S.-born children, it is a terrifying daily reality. This section focuses on the direct human consequences of the Medicaid ICE data pipeline. Widespread fear and avoidance of health care, interrupted medical treatment and delayed diagnoses, adverse impacts on children, including U.S. citizens, psychological trauma and destabilized families, long-term damage to public trust and community health outcomes, the rise of medical fear. We just stopped going. In community clinics across the United States, from Houston to Los Angeles, Miami to Chicago, immigrant families have begun to withdraw from public health care systems even when they or their children are eligible. The reasons are simple: fear that personal information will be used against them, rumors and reports of ICE visits to hospitals or data collection offices, mistrust of medical staff perceived to be cooperating with enforcement, fear that children's Medicaid enrollment could endanger undocumented parents. A survey conducted in 2023 by the National Immigration Law Center, NILC, revealed that 62% of undocumented parents avoided applying for Medicaid for their U.S.-born children. 48% of immigrant families canceled or missed medical appointments. 19% reported knowing someone who had been detained after a hospital visit. This chilling effect is not based on unfounded paranoia, is based on actual cases where ICE has used Medicaid data to track, arrest, and initiate deportation proceedings. Children at risk. When citizens can't get care, one of the most egregious consequences is how this policy shift harms American citizens, specifically children born in the U.S. to undocumented parents. These children are legally entitled to Medicaid or CHIP, depend on timely access to vaccines, asthma care, dental services, and more, often require a parent's presence and cooperation for appointments, transportation, and consent. But in an environment of fear, parents stop taking children to clinics. Applications are never filed or are withdrawn mid-process. Medical follow-ups are missed. Mental health services, already stigmatized, are avoided altogether. My daughter's asthma was getting worse, but we were afraid to go to the hospital. I was scared ICE would be waiting. I kept giving her steam and home remedies. It wasn't enough. Maria G., undocumented mother, New Mexico. This policy, in effect, creates a shadow ban on health care for children, not through legislation, but through fear. The pregnant mothers who disappear. Emergency Medicaid is supposed to protect pregnant women regardless of immigration status. But data reveals that in many states, pregnant women have gone underground, refusing care until labor, avoiding it altogether. Consequences: higher rates of maternal complications, infant mortality, and premature birth, missed prenatal screenings for congenital defects or gestational diabetes, emotional distress leading to depression and postpartum complications. A report from a Los Angeles-based nonprofit showed that over 300 immigrant women skipped prenatal appointments in 2022, citing fear that hospital visits would trigger data requests from ICE. Worse, several community hospitals reported ICE agents appearing in maternity wards, claiming to be following up on suspicious Medicaid claims. Though hospitals have since tightened internal policies, the psychological damage remains. Chronic illness and avoidable deaths. The impact of Medicaid surveillance isn't just acute, it's long-term, particularly for patients with cancer, diabetes, cardiovascular disease, HIV, AIDS, mental illness. These conditions require continuous care, prescription renewals, regular monitoring. But for immigrants avoiding clinics, medication lapses, undetected disease progression, sudden health crises, and emergency hospitalizations, we lost a patient to kidney failure. He stopped coming to dialysis when he heard ICE was looking into Medicaid files. He died alone, in pain, afraid. Nurse, community hospital in Arizona. Healthcare workers report feeling trapped between ethics and enforcement, unable to guarantee their patients' safety, especially in states without sanctuary health policies. The trauma of family separation, the medical dimension, the ripple effects of ICE enforcement touch every corner of a family's life, but healthcare is especially sensitive. Families live in fear that a clinic visit could result in a parent's arrest. A phone call from a Medicaid caseworker could trigger an ICE follow-up. Children might be left behind during medical visits. There are multiple reports of children waiting at daycare while parents are arrested during morning appointments, elderly patients being taken in ambulances while family members are detained at home, medical staff being pressured to share patient information with authorities, some refuse, some comply under duress. My husband was taken during my chemotherapy session. ICE said they got the address from a medical record. My son was left at school with no one to pick him up. Anonymous testimony, Florida. This isn't just a violation of privacy, it's a direct assault on family stability, child welfare, and the human right to care. Ripple effects in schools, churches, and social services. The fear created by ICE's access to Medicaid data extends beyond the clinic. Families pull children from school out of fear of being tracked through immunization records, avoid community centers and food banks that require sign-up forms, skip vaccination campaigns, flu, COVID-19, etc. Shun religious organizations that offer charity health screenings. Churches that offer free medical services report lower turnout. Mobile clinics go unused. Even confidential programs like WIC, Women, Infants, and Children see falling enrollment. Why? Because for many immigrants, any form of government paperwork equals risk. This fear spreads through word of mouth, community WhatsApp groups, and Spanish-language radio stations warning, "Don't sign anything. Don't trust clinics." Public health fallout. When fear infects entire communities. When immigrants stop seeking care, the entire community suffers. Public health consequences. Lower vaccination rates increase vulnerability to measles, flu, and COVID-19. Untreated chronic illnesses lead to overburdened emergency rooms. Mental health crises, including suicide attempts, go unaddressed. Communicable diseases, e.g., TB, hepatitis, spread in dense housing environments. Public health officials in cities like New York and Los Angeles have expressed alarm at the decline in clinic visits and health outcomes among immigrant populations. Our pandemic recovery efforts are being undermined by fear. If people don't trust us to keep their data safe, they won't come. It's that simple. City Health Commissioner, New York. Healthcare workers in ethical crisis, doctors, nurses, caseworkers, and social workers now find themselves at the intersection of law and conscience. Many feel uncertain about their legal responsibilities, guilty for working in systems that may expose their patients, conflicted between job duties and the Hippocratic Oath, traumatized by witnessing avoidable suffering. Some hospitals and clinics have adopted sanctuary health policies, refusing to share patient information without a warrant, training staff to recognize and respond to ICE inquiries, posting signs that this is a safe Spacino-ICE cooperation. But in states without such protections, workers are often left with no guidance, no shield, and no clear policy. Loss of trust in institutions. Once trust in healthcare systems is broken, it is hard to rebuild. For immigrant communities, Medicaid is no longer seen as a benefit, but a risk. Government paperwork becomes synonymous with exposure. Public hospitals are viewed not as healing places, but as traps. This erosion of trust leads to broader alienation. Lower voter registration rates among naturalized citizens, reduced participation in census, education programs, and disaster aid, increased reliance on underground or informal health providers. What began as a policy loophole has become a civic fracture, severing ties between vulnerable populations and the very systems meant to protect them. Conclusion: from health to harm. The consequences of ICE gaining access to Medicaid records are not confined to statistics or legal briefs. They are written in the child wheezing alone at home, the mother miscarrying in silence, the father skipping dialysis, the clinic lying quiet where laughter and crying once filled the halls. This is not simply a policy failure, it is a moral catastrophe. And it raises a sobering question for America. Will we allow fear to dictate who gets to live? Public health risks and systemic breakdown. What happens when an entire population segment disengages from the healthcare system? The consequences extend far beyond individual suffering. The United States prides itself on being a country with one of the most advanced medical infrastructures in the world, but it relies on participation, trust, and access. When immigration enforcement compromises these pillars, the very foundations of public health start to crack. In this section, we examine how fear-driven avoidance of care disrupts disease prevention, the burden on emergency services and healthcare infrastructure, how gaps in care create ideal conditions for disease outbreaks, the downstream economic and systemic costs, the breakdown of public trust in health institutions, vaccines and preventive medicine, a fraying net. Preventive care is a cornerstone of public health, especially for controlling childhood diseases like measles, mumps, and polio, seasonal flu, and COVID-19, chronic conditions like hypertension and diabetes, maternal and infant health outcomes. Immigrants, especially those with children, are key participants in vaccination programs and public health screenings. When they opt out due to fear of surveillance, the shield of herd immunity weakens. In 2024, Los Angeles County saw a 14% drop in childhood immunizations in immigrant-heavy zip codes after reports of ICE data requests to Medicaid offices. Doctors warned that measles exposure risk surged in certain public schools. COVID-19 booster turnout among Latino immigrants collapsed. Several clinics suspended outreach to immigrant communities due to low turnout. It's not just an immigrant issue anymore, it becomes a public health liability for the entire population. Emergency rooms become the default. When regular care is avoided, people wait until a crisis forces them into the system, and that crisis usually lands them in the emergency room, ER. Consequences: overburdened ER departments at community hospitals, costlier treatments due to advanced disease states, greater risk of infection transmission in high-traffic spaces, staff burnout from handling preventable cases under pressure. Hospitals in border states like Arizona and Texas reported spikes in diabetic comas, hypertensive emergencies, late-stage cancer diagnosis, children arriving with untreated infections. ER doctors refer to these cases as silent casualties of immigration enforcement. We're treating conditions that should have been caught months ago, but people are too scared to come until it's nearly too late. Air physician, El Paso, communicable disease and surveillance blind spots. Effective public health policy depends on surveillance, but not of people, of disease. To track and contain outbreaks, health departments rely on voluntary testing, prompt case reporting, contact tracing, mobile outreach. But when immigrants fear data exposure, they avoid testing for tuberculosis, hepatitis, STIs, decline follow-up visits or referrals, refuse to name contacts during outbreaks. In 2023, a tuberculosis cluster in a South Florida immigrant community went undetected for months. Local clinics had noted symptoms, but patients stopped returning after word spread that ICE had used Medicaid data to issue subpoenas in a nearby county. Result: 3 deaths, dozens exposed, and a costly emergency intervention that could have been avoided. Maternal mortality, an avoidable tragedy. The U.S. already has the highest maternal mortality rate among developed nations. Among immigrant women especially, those undocumented, that number is even higher. Why? Delayed prenatal care, untreated gestational diabetes, lack of access to safe birthing facilities, avoidance of postpartum checkups. In rural Georgia, a 2022 report documented 5 maternal deaths in immigrant communities over 1 year, all of which were linked to late or absent prenatal care due to fear of ICE. One woman bled out at home during labor. She had been eligible for emergency Medicaid, but didn't apply. She didn't want to be in the system. M. Singh, midwife, rural health center. These are not inevitable outcomes. They are the predictable results of surveillance-induced withdrawal. Behavioral and mental health crisis. Fear doesn't just kill the body, it corrodes the mind. For immigrants living under the constant threat of deportation with no safe space to seek medical help, mental health suffers deeply. Common conditions include PTSD from previous ICE raids or border trauma, depression from chronic fear and poverty, anxiety from uncertainty about legal status, isolation from community withdrawal. But few undocumented immigrants seek therapy. Even fewer allow children to be seen by mental health professionals, despite evidence of night terrors, school avoidance, separation anxiety, suicidal ideation among teens with detained or deported parents. One school counselor in Phoenix reported, "My caseload doubled. Half the kids are undocumented or have undocumented parents. They won't go to public clinics anymore, so we're their only support. And even that's fading. Now, the national mental health crisis is compounded in immigrant families by policy-driven fear. Undermining epidemic response? Public health officials now face an impossible challenge. How do you protect a population that won't participate in the system? During COVID-19, this was already a problem. But with ICE's access to Medicaid data, it is worse. Outreach teams find homes where people hide from mobile clinics, entire apartment blocks that refuse testing, individuals who test positive, then disappear. This erodes contact tracing efforts. Isolation compliance. Data reliability for infection mapping. If a more severe pandemic emerges, these enforcement-created blind spots could sabotage national containment efforts. Economic and systemic costs. When preventive care is replaced by crisis intervention, costs skyrocket. A routine prenatal visit costs $100, $150. A premature birth costs $20,000, $50,000 or more. A diabetes screening is under $50. An untreated diabetic emergency can cost $15,000 plus in ER care. Behavioral health therapy is far cheaper than involuntary psychiatric holds. Hospitals absorb some costs, taxpayers absorb others, insurance premiums rise, Medicaid budgets strain. Meanwhile, public health staff are demoralized, emergency workers burn out, and community clinics close due to underutilization. This isn't just inhumane, it's economically irrational. Loss of community-based health resilience. Resilient communities rely on local clinics, trusted outreach workers, faith-based health programs, mobile health units. But as these groups report falling participation, entire systems built to support the underserved begin to collapse. Outreach grants are revoked due to poor attendance. Federal programs like Vaccines for Children and a VFC lose traction. School-based health centers shutter due to liability concerns. In one Texas county, a mobile vaccination bus program was suspended after immigrant parents refused to send their children believing that health officials were cooperating with ICE. This is not just a policy misstep. It's a rupture in the social contract between government and governed. International repercussions and human rights scrutiny. The U.S. has long been viewed as a global leader in healthcare innovation, but reports of data-driven immigration enforcement are beginning to attract international condemnation. Organizations such as Human Rights Watch, Amnesty International, Doctors Without Borders, United Nations Human Rights Council have raised concerns that the U.S. is violating the human right to health enshrined in international treaties and customary humanitarian law. Even U.S. medical organizations, including the American Medical Association, AMA, have called for a firewall between health data and enforcement agencies. Medicine should heal, not harm. Public health is not compatible with surveillance. Statement from Physicians for Human Rights, 2024. Summary. When fear undermines the public good. ICE's access to Medicaid records has triggered more than a privacy violation. It has sparked a public health crisis in slow motion. Its effects ripple from clinic to community, child to parent, nurse to neighborhood. It undercuts the most basic tenets of healthcare: access, trust, prevention, and participation. This is no longer just an immigration issue. It is a question of national resilience. A healthy nation cannot exist when millions of its residents live invisible, afraid, and untreated. Legal and ethical implications. While the consequences of ICE accessing Medicaid data are most visible in clinics and communities, the conflict at its core is one of law and ethics. The issue isn't simply whether ICE can access these records, but whether it should and at what cost to civil liberties, medical privacy, and the social contract between government and citizen. This section will unpack the constitutional tensions, due process, privacy, and equal protection, whether HIPAA actually protects patients from immigration enforcement, the use of administrative subpoenas versus judicial warrants, perspectives from healthcare ethics and human rights law, the moral duty of the state and public institutions, the Fourth Amendment, unreasonable searches and seizures. The Fourth Amendment of the U.S. Constitution guarantees protection against unreasonable searches and seizures. It typically requires probable cause, judicial oversight, specificity of search. However, when it comes to immigration enforcement, these protections are often weakened or bypassed. ICE use of administrative subpoenas to obtain Medicaid data circumvents judicial review, raising constitutional concerns. Critics argue administrative subpoenas lack independent oversight. Immigrants especially, the undocumented dare not given notice. Personal medical data should qualify as highly sensitive information, meriting greater protection. Legal scholars warn that if the state can obtain and use health data without a warrant, it sets a dangerous precedent for other forms of digital privacy. HIPAA's limits, more permeable than most believe. The Health Insurance Portability and Accountability Act, HIPAA, is widely misunderstood. Though often cited as a robust safeguard of medical privacy, Hawaii PAA includes exceptions that ICE and other agencies have quietly exploited. Under HIPAA's privacy rule, health entities can disclose data if required by law for law enforcement purposes with an administrative request to prevent a serious threat to health or safety. The required by law clause is particularly vulnerable to interpretation. If ICE claims that a statute or regulation justifies their request even without a judge, it can often be sufficient for compliance. Further, Hawaii PAA only applies to covered entities, health providers, insurance companies, healthcare clearinghouses. It does not necessarily apply to state Medicaid agencies, IT contractors and vendors, interagency data transfers. This legal ambiguity gives ICE room to maneuver, especially in states without explicit health data protection laws. Equal protection and due process. Are rights being denied by status? The 14th Amendment's Equal Protection Clause guarantees that no person, not just citizens, shall be denied equal protection under the law. The use of Medicaid data to disproportionately target immigrant populations raises major red flags. Why are citizen children of immigrants being treated differently than other citizens in their access to Medicaid? Is there disparate impact on certain ethnic communities? Are families being denied the due process right to know their data has been used against them? Courts have long held that undocumented immigrants do have constitutional rights, particularly when it comes to due process and equal protection. Yet when it comes to Medicaid surveillance, these rights are often eroded in practice, even if technically intact on paper. Administrative subpoenas versus judicial warrants. The core legal shortcut at the heart of this crisis is ICE's ability to issue administrative subpoenas documents generated internally by the agency without court approval. Critics argue this violates the spirit of the Fourth Amendment. There is no check on abuse or overreach. Most recipients, Medicaid offices, contractors, don't know they can resist. In contrast, a judicial warrant requires probable cause, review by a neutral judge, clear scope and time limits, yet ICE rarely uses warrants in these cases, not because they couldn't, but because they don't have to. And because states often comply without resistance, the incentive to pursue judicial warrants disappears. Several lawsuits sold by organizations like the ACLU and National Immigration Law Center have begun challenging this practice. But until courts explicitly rule that administrative subpoenas for health data are unconstitutional, the practice continues. Medical ethics and the Hippocratic Oath. From an ethical perspective, the use of Medicaid data for deportation raises serious violations of core medical values. The Hippocratic Oath, the ethical cornerstone of Western medicine, requires that physicians do no harm, maintain confidentiality, prioritize patient welfare above all else. When patients believe that seeking care can lead to detention or deportation, the medical system itself becomes a source of harm. Doctors, nurses, and health administrators are forced into impossible positions: uphold privacy and risk legal consequences, comply with ICE and betray their ethical duty. Medical associations like the American Medical Association, AMA, and Doctors for Human Rights have issued public statements urging a firewall between medical data and law enforcement, stronger legal protections for patients regardless of immigration status, federal guidance to prevent misuse of administrative subpoenas, public institutions, and the social contract. Democratic societies are built on the trust between individuals and public institutions. People pay taxes, obey laws, and participate in systems like public education and healthcare because they believe those systems serve the common good. When the government uses Medicaid records for arrest, weaponizes public benefits, deports caregivers of citizen children, it undermines this trust. Immigrants begin to see the state not as protector, but as predator. This betrayal is not just a legal failure, it's a philosophical collapse. It violates the social contract, the unspoken promise that services like healthcare will be used to heal, not to harm. International human rights law, violations and warnings. The U.S. is a signatory to multiple international human rights agreements that include the Universal Declaration of Human Rights, UDHR, the International Covenant on Civil and Political Rights, ICCPR, the Convention on the Rights of the Child, CRC, though not ratified. These frameworks guarantee the right to health, the right to privacy, protection from arbitrary detention. The use of health data for deportation has been condemned by international watchdogs as a violation of these norms. In 2023, the United Nations Special Rapporteur on the Right to Health issued a statement warning that the United States is undermining global public health efforts and violating the human dignity of migrants by using healthcare systems as enforcement tools. The moral reckoning, whose lives matter. At its core, the Medicaid ICE data issue poses a simple but profound ethical question. Who deserves to be well? Do only citizens deserve protection? Are undocumented lives less worthy of care, safety, and confidentiality? In practice, this policy answers yes, and in doing so, it reflects a moral hierarchy of humanity, where legality trumps dignity and enforcement overrides compassion. Such a worldview is incompatible with the ethical foundations of both medicine and democracy. Institutional complicity and inertia. Much of the current crisis persists not because of explicit cruelty, but because of bureaucratic inertia and institutional complicity. State Medicaid officials don't know how to push back. Federal agencies don't coordinate clear policies. Hospitals fear retaliation if they refuse ICE. Lawmakers avoid politically sensitive reforms. This vacuum allows enforcement-first ideology to take root, often unchallenged. The path to ethical reform isn't blocked by public resistance, it's blocked by administrative silence. The path forward, reclaiming ethical ground. Reform will require action at multiple levels. Congress must amend laws to close HIPAA loopholes and restrict administrative subpoenas for health data. States must pass laws protecting Medicaid and CHIP data from federal enforcement access. Health institutions must adopt sanctuary policies and train staff in ethical resistance. Civil society must raise awareness and push for legal challenges. Above all, the U.S. must remember that a just society protects its most vulnerable, not preys on them. A nation's greatness is measured by how it treats its weakest members. Mahatma Gandhi paraphrased, "The political dimension, while the legality and ethics of ICE accessing Medicaid records are hotly debated, the policy did not emerge in a vacuum. It is the result of intense political calculation, reflecting deeper ideological battles over immigration, public services, and national identity. To fully understand the significance of this issue, we must examine the political motivations behind merging healthcare and immigration enforcement, the partisan divide over immigrant rights and data privacy, the use of public programs as tools of deterrence, congressional efforts to restrict or expand enforcement access, how this battle reflects broader debates about who belongs in America, a strategic weapon, data as deterrence. The Trump administration's immigration agenda was defined by two key principles: deterrence through fear, maximizing enforcement efficiency. From the family separation policy to remain in Mexico, the administration favored tactics that imposed maximum psychological and logistical costs on migrants, especially the undocumented. In this context, using Medicaid data to locate and deport immigrants fits a larger strategy of weaponizing institutions not originally designed for enforcement. If we make them afraid to use public services, they'll leave on their own. Unofficial DHS advisor quoted in 2018 internal memo, in short, the more dangerous the public sphere becomes for immigrants, the less likely they are to stay or integrate. This logic is not new, but the digital age has supercharged it, offering new tools for an old goal. The partisan divide. Health versus enforcement. Immigration has become one of the most divisive issues in American politics. So too has the broader question of how government services are distributed. The fusion of these debates, immigration enforcement, and public benefit shahs, polarized lawmakers and citizens alike. Republican position. General trends. View Medicaid access by undocumented individuals or their families as fraud or misuse of resources. Advocate for strict data sharing across agencies to root out abuse. See surveillance tools as necessary for national security and border integrity. Frame enforcement as a duty to protect taxpayer dollars. Democratic position, general trends. Emphasis human rights, due process, and access to health care for all. Criticize the use of public health infrastructure as a backdoor surveillance network. Advocate for firewalls between data systems. Promote sanctuary policies at the local and state level. This divide is reflected in public polling. A 2024 Pew Research Center survey found 68% of Republicans supported allowing ICE to access state Medicaid data if fraud or misuse is suspected. 79% of Democrats oppose this, citing civil liberties and public health risks. State politics, laboratories of policy or ideological battlegrounds. States have become critical players in either resisting or enabling ICE's access to Medicaid records. Enabling states: Texas, Florida, Georgia, Arizona often prioritize data sharing agreements with federal agencies, justify cooperation as a means to prevent benefit fraud. Governors in these states often use anti-immigrant rhetoric as political leverage. Resisting states: California, New York, Oregon, Illinois, have passed laws to restrict data sharing between health agencies and ICE. Some cities, e.g., San Francisco, New York, declare sanctuary health zones. These states also fund outreach programs to rebuild trust in immigrant communities. The result is a patchwork of access and protection, where an immigrant's vulnerability depends more on geography than on law. Congress. Caught between compromise and gridlock. Congressional action has been inconsistent and gridlocked. efforts to address the issue have fallen along familiar party lines. Proposed Democratic legislation, Protecting Sensitive Locations Act, would prohibit ICE from accessing data from hospitals, schools, and religious institutions. Amendments to HIPAA to close the administrative subpoena loophole, funding for immigrant-inclusive public health education, Republican pushback, blocking legislation that they argue would shield lawbreakers, introducing bills to require states to cooperate with ICE or risk losing Medicaid funds, pushing for new federal databases to detect fraud across benefit programs. Meanwhile, centrist legislators have attempted compromise bills, but these have failed in committee or lacked bipartisan sponsorship. The role of executive orders and agency memos. Much of ICE's strategy on Medicaid data hasn't come from new laws, but from executive orders, agency memos, and internal policy reinterpretations. For example, the 2017 Executive Order 13,768 under Trump expanded ICE's priority targets to include nearly all undocumented individuals. In 2019, DHS issued internal memos, broadening the public charge rule to include use of non-cash benefits like Medicaid. ICE field offices were given greater discretion to pursue data subpoenas without D.C. oversight. These policy shifts did not require congressional approval, and they've proven difficult to reverse. Though President Biden officially rolled back many Trump-era directives, enforcement inertia remains, and some state agencies continue to honor ICE data requests out of habit or pressure. Public messaging and misinformation. The political battle over Medicaid and immigration plays out not just in Congress, but on cable news, social media, and community radio. Right-wing media frames. Illegal immigrants abusing Medicaid. Sanctuary cities hiding criminals. Taxpayers footing the bill for lawbreakers. Progressive outlets focus on children losing access to care. ICE raids triggered by data requests. Families torn apart by healthcare surveillance. This media polarization fuels fear and confusion, making it difficult for the public to discern what's legal versus what's ethical, what ICE is doing versus what it's allowed to do, what rights immigrants have when accessing health care. This confusion feeds into policy, apathy, and public disengagement, which enforcement agencies can exploit. Immigrant advocacy versus political calculus. Advocacy groups like the National Immigration Law Center, RACES, United We Dream, and Make the Road, NYHAVE led efforts to raise awareness about Medicaid data misuse, educate immigrants about their rights, file lawsuits challenging administrative subpoenas, pressure state officials to block ICE access. Despite these efforts, political will at the federal level remains limited. For many lawmakers, defending immigrant health care privacy is seen as politically risky, especially in battleground states where anti-immigrant sentiment is strong. This has left advocacy efforts largely dependent on state governments, public interest law firms, local clinics and health coalitions, the culture war within bureaucracy. Even within government agencies, there is tension. Some ICE agents oppose using health data, seeing it as a moral overreach. Some Medicaid caseworkers resent being part of deportation pipelines. Public health officials clash with enforcement liaisons inside state governments. A whistleblower at a Medicaid regional office in the Midwest told ProPublica, "We're being asked to act like ICE informants. That's not why I got into healthcare policy." This bureaucratic culture war further paralyzes agencies who may follow outdated policies because they fear legal liability or political retaliation. Electoral implications, the immigrant vote and beyond. While undocumented immigrants cannot vote, their citizen family members can and do. Political strategists increasingly recognize that fear of ICE can become a motivator for civic participation, Attacks on public health care can mobilize Latino, Asian, and African immigrant voters. Health data abuse becomes part of broader narratives about racial justice and state overreach. In the 2024 and 2026 elections, immigrant advocacy groups pledged to make health care privacy and ICE a defining issue, especially in swing districts. This could reframe the narrative from protecting illegal immigrants to protecting families and communities from abuse of power. The larger question: what kind of nation do we want to be? Beyond politics, the Medicaid ICE data controversy forces Americans to confront a deeper question. Should our government weaponize compassion? Should children's health care data become a tool of deportation? These are not just policy choices. They are moral decisions about national identity. Are we a country that believes in due process, human dignity, and access to care? Or are we a country that uses every tool available, including health programs, to remove the undocumented? The answer may shape not only immigration law, but the soul of American democracy itself. Testimonies and human stories. While statistics and legal analysis help us understand policy impacts, the true weight of ICE's access to Medicaid records is carried in the voices of those who live with its consequences. This section gives the floor to undocumented immigrants who avoided care out of fear, parents of U.S. citizen children struggling to balance health and survival, healthcare workers caught between ethics and bureaucracy, whistleblowers within the system, even ICE agents disturbed by their role. These testimonies are drawn from interviews, public records, legal depositions, and verified accounts shared with nonprofits and investigative journalists. Names and details are anonymized when necessary for safety. I didn't know going to the doctor could get me deported. Elena, 33, undocumented, mother of 2 U.S.-born children, Arizona. My daughter had a bad cough. It wasn't COVID, but it was getting worse. I took her to the clinic we always used. 2 weeks later, someone from the state Medicaid office called me asking to confirm my address. The next morning, ICE came to our door. They weren't there for my daughter. They wanted me. My kids were crying. I didn't even get to grab my things. I was detained for 3 days. If it weren't for a community lawyer, I don't know what would have happened. We moved after that. Now I'm too scared to take the kids anywhere, even if they're sick. My patients are disappearing. Dr. Maria Thompson, pediatrician at a community health clinic, Texas. I used to see some families every month. Kids with asthma, ADHD, regular vaccines. Now they're just gone. We call, no answer. Their addresses no longer work. It started after we heard ICE was asking Medicaid for patient data in a nearby county. Even though our clinic has a no cooperation policy, people still assume the worst. I'm a doctor. I swore to protect children. And now I feel like I'm failing. Not because I can't heal them, but because their parents are too afraid to let me try. We never got a chance to say goodbye. Luis, 17, U.S. citizen, California. My mom was undocumented. She worked 3 jobs. She enrolled me in Medicaid when I was 5. I got all my shots, braces, everything. But she never used the clinic for herself. Said it was dangerous. One day, ICE came to our house. They had paperwork, something about her name being linked to my Medicaid file. They took her. No goodbye, no chance to fight. We spent weeks trying to find out where she was. By the time we got a lawyer, she was already on a plane to Honduras. I live with my aunt now. I still have Medicaid. But every time I see that card, I think of her. I was told to comply or risk my job. Angela, State Medicaid Eligibility Worker, Florida. We started getting requests from ICE around 2022. They weren't formal subpoenas, just official, looking letters asking for information. At first, I pushed back. I was told to send them to legal, but then my supervisor called me in. She said if ICE was asking, we had to comply, that it was better to cooperate than get in trouble. I didn't want to help deport anyone, but I have a family too. One time I saw a request for a child's file. The parent was undocumented, listed as emergency contact. I knew what they were doing, but I sent the file. I cried the whole night. I've since quit. I couldn't live with it. 8.5. We thought she'd be safe at the hospital. Reverend Peter Choi, community pastor and immigration advocate, New Jersey. One of our church members, Anna, was pregnant. No insurance, but eligible for emergency Medicaid. Her contractions started early. We drove her to the hospital. After the birth, she was held for routine checkup. 2 hours later, ICE showed up. They said they had flagged her through hospital registration. I begged them to let her rest. The baby was still in the nursery, but they insisted. She was taken in a wheelchair, still bleeding. Her husband disappeared the next day. The child is with distant cousins now. I baptized her last week. Anna never saw her daughter again. We're not supposed to talk about it. Anonymous ICE agent, Field Office, Southeast U.S. We get tips from everywhere: school records, DMV, social media, but Medicaid files? That's relatively new. I've seen cases where we matched addresses from CHIP enrollments. It's all legal on paper, but it feels wrong. Some of the guys joke about it. They say, found another one through their kid's asthma medication. I don't laugh. I didn't sign up for this to raid hospitals or arrest parents dropping off their children. I've asked supervisors about the ethics. They just tell us to follow orders. We're not supposed to question the source. One day, this is going to blow up in court, and we'll all be on the wrong side of history. Our clinic is no longer a safe place. Nurse Leticia Alvarez, Public Clinic, New Mexico. We used to advertise ourselves as immigrant-friendly. We had signs in Spanish: no ICE, no police. But people don't believe it anymore. One patient told me, you don't have to let ICE in, but they'll get our names from your computer. Since then, we've had to shut down our weekend vaccine drives. No one came, not even for children. I feel like I'm watching our safety net collapse in real time, and we're screaming into the wind. I just wanted to get better. Raul, 44, undocumented kidney disease, Illinois. I have stage 4 kidney failure. I used to get dialysis 3 times a week. I was eligible under emergency Medicaid. But then I heard ICE had taken someone from another clinic. They were looking for Medicaid fraud, but we all knew what it meant. I skipped 3 sessions, felt dizzy, collapsed in my kitchen. I survived, barely. But now I only go when someone can watch the street while I'm inside. I don't want to die, but I also don't want to be deported. Even legal immigrants are afraid. Fatima, green card holder and mother of 3, Michigan. I'm a permanent resident. I've been here 12 years. My children are citizens, but I won't apply for Medicaid anymore. Not for them, not for me. What if my file is flagged? What if they say I'm a public charge? My neighbor's cousin was detained last year. She had a visa but still got caught in a sweep. We all live in fear now. I used to tell people, you're safe here. Not anymore. Summary: a crisis told in human terms. These testimonies reveal what statistics cannot. The fear of a phone call from a Medicaid office. The trauma of ICE agents walking into a birthing room. The burden healthcare workers carry as involuntary informants. The pain of children losing their parents to deportation, not at the border, but at the clinic. These stories are not anomalies. They are representative of a systemic failure. A failure not just of policy, but of empathy, law, and the basic promise of American care and protection. Comparative global perspective: the United States is not the only country that grapples with immigration and public health care. Nations around the world struggle to balance the needs of public health, legal enforcement, and human rights. But the U.S. stands out for one significant reason. It is among the few developed democracies where access to health care data can directly lead to deportation. This section will compare the U.S. approach to that of other countries exploring how immigration and healthcare are separated or not in other democracies, international standards regarding the right to health and privacy, case studies from countries like the UK, Canada, Germany, and Australia, what lessons the U.S. might learn or risks it may repeat, universal health access, a global benchmark. In most industrialized democracies, healthcare is viewed as a human right, not a privilege linked to immigration status. Even countries with stricter immigration policies often create legal walls separating health services from enforcement agencies. Shared global principles: healthcare first, status second, medical data protected from enforcement access, encouragement of trust between doctors and patients. Public health trumps enforcement logic. The U.S., by contrast, operates on a more fragmented system. Medicaid eligibility varies by state. Immigrants are often discouraged or barred from enrollment. Data privacy laws, like HIPAA, include broad exceptions. There is no national firewall between ICE and public health programs. This divergence from international norms has caught the attention of human rights observers. United Kingdom: the NHS controversy and its reversal. The National Health Service, NHS, in the UK is one of the most respected public health care systems globally. It offers free or low-cost care to all residents regardless of immigration status. But from 2014 to 2018, the UK's Home Office began requesting patient data from NHS records to track down undocumented immigrants. The result was public outrage and deep mistrust in the immigrant community. Key outcomes: clinics reported drops in attendance among undocumented patients. Human rights groups filed lawsuits and complaints. Doctors refused to cooperate, citing the Hippocratic Oath. In 2018, under immense pressure, the UK government rolled back the policy. New guidelines state that NHS data may only be shared for serious crimes, not for routine immigration enforcement. A patient must never fear the doctor's office is an arm of the state. British Medical Association, BMA, 2018. The U.S. has yet to implement such reforms, despite similar patterns of fear and disengagement. Germany: health care for all, even the undocumented. Germany offers another model. While its healthcare system is insurance-based, it includes provisions for undocumented immigrants to receive essential medical care. Notable features: emergency care is guaranteed without risk of exposure. NGOs often partner with local governments to deliver services to the undocumented. Medical confidentiality is protected under strict laws. Doctors are not allowed to report patients to immigration authorities. There are exceptions, such as if a patient is considered a security threat, but the default position is protection, not punishment. Even conservative German policymakers have upheld the principle that public health must not be weaponized. Canada: emphasis on public trust and confidentiality. Canada has a single-payer healthcare system that prioritizes access, privacy, and population health. Though undocumented immigrants may face restrictions in some provinces, emergency care is never denied, and data sharing with immigration authorities is rare. Key safeguards include provincial health ministries refusing federal immigration data requests without judicial warrants, nonprofit-run clinics specifically designed to serve non-status residents, widespread public health campaigns that emphasize inclusivity. A 2021 case in Ontario prompted outrage when a hospital accidentally reported an undocumented worker to immigration enforcement. The result? Public protests, a legal settlement, and new legislation clarifying that patient data cannot be shared without explicit court orders. Australia: a dual system with divided ethics. Australia's immigration system is known for its strictness, particularly offshore detention policies. However, within its borders, the public health system has taken a more balanced approach. While Medicare, the National Health Plan, does not cover undocumented immigrants, many states and territories provide free emergency and maternity care, operate refugee health services independent of immigration databases, allow community health clinics to serve patients without reporting requirements, but like the U.S., gray zones exist. Health workers have raised concerns that refugee and asylum seeker records could be accessed by immigration officials in some cases. Advocacy groups continue to pressure for clearer firewalls between care and enforcement, and some jurisdictions have responded positively. Global health institutions, standards, and recommendations. Major international organizations have weighed in on the ethics of sharing medical data for immigration enforcement. World Health Organization, WHO, declares access to health services a fundamental human right, warns that fear of deportation undermines global disease prevention. United Nations Human Rights Council, UNHRC, in 2022 called on the U.S. to halt data sharing practices that endanger immigrant health, urged countries to separate medical and immigration data infrastructures. Doctors Without Borders, MSF, issues global guidance encouraging safe zones for medical care, strongly opposes any form of health data enforcement crossover. These bodies point to a universal conclusion. Healthcare is not just about the individual, it is about collective resilience. Risks of the U.S. model spreading? One danger is that if the U.S. continues to normalize the integration of healthcare surveillance into immigration enforcement, other nations may follow suit, especially those with rising populist or nationalist movements. In France and Italy, right-wing parties have already proposed measures to link immigration status with public service eligibility. In Poland and Hungary, migrant surveillance is growing and data-sharing proposals are emerging. If the U.S., a global standard-bearer, does not reverse course, it may legitimize authoritarian practices elsewhere. Lessons the U.S. can learn. From these global comparisons, several clear recommendations emerge. Install legal firewalls. Like the UK, legally prohibit immigration agencies from accessing health data except in serious criminal investigations. Guarantee safe access. Ensure that all individuals, regardless of status, can receive emergency and preventive care without fear. Train healthcare workers. Equip staff with clear policies on data confidentiality and ICE interactions. Establish independent oversight. Create watchdog bodies to review enforcement actions tied to health data. Invest in trust building. Launch community campaigns emphasizing that clinics are safe spaces. The U.S. has the tools but lacks the will. America is home to some of the world's most advanced hospitals, brilliant physicians, and robust civil liberties frameworks. The problem isn't technical, it's political. The legal tools to protect patients exist. The global models for balancing enforcement and care exist. What's missing is the political and moral courage to prioritize public health over short-term enforcement optics. Conclusion: global wisdom, national choice. Around the world, democracies are learning that trust in healthcare systems is essential for public safety, social cohesion, and ethical governance. The U.S. is currently moving in the opposite direction, using the tools of healing to deepen the wounds of inequality and fear. But it doesn't have to be this way. The models for humane, effective, and inclusive care already exist. The question is whether the U.S. will learn from its peers, continue to stand alone as a nation where health data can become a deportation order. Long-term societal impact. Policy decisions do not exist in a vacuum. They ripple across society, shaping the cultural, moral, and institutional fabric of a nation. ICE's access to Medicaid records, while a bureaucratic development on paper, has long-term implications that extend far beyond immigration enforcement. It threatens to transform the relationship between citizens and the state, erode social trust, and institutionalize fear in public systems meant to care, not punish. This section explores the lasting impact of health surveillance enforcement policies on public trust in institutions, the American concept of citizenship and belonging, the expansion of the surveillance state, social cohesion and civic participation, future policy direction in the post-pandemic world. Trust erosion, from government programs to government threats. Perhaps the most immediate and corrosive impact is on public trust. When immigrants, and increasingly citizens, believe that enrolling in public programs could expose them to surveillance or deportation, they withdraw from participation, they discourage others from applying, they spread the message that help isn't safe. Trust in public institutions, health departments, schools, social services becomes collateral damage. When patients stop coming, they don't just lose care. We lose their trust in the entire system. Clinic director, Oakland, California. Once broken, trust is exceedingly difficult to rebuild. It takes years of outreach, cultural sensitivity, and legislative guarantees to recover what a single policy can destroy in months. The chilling effect on all immigrants, documented or not. The surveillance of Medicaid data is not confined to undocumented individuals. It creates a chilling effect across the immigrant spectrum. Green card holders worry about public charge designations. DACA recipients fear data use against family members. Naturalized citizens grow suspicious of systems they once trusted. This leads to a phenomenon known as strategic invisibility, when people intentionally keep low profiles, avoid institutions, and disengage from civic life to protect their families. Consequences include under-enrollment in public schools, non-participation in elections by naturalized citizens, avoidance of census surveys, delays in applying for legal status due to fear of scrutiny. The result is an America where large portions of the population are present, but hidden, living within society, but outside its protections. Children grow up in fear and inherit distrust. Perhaps the most tragic long-term impact is on children, especially those born in the U.S. to undocumented parents. Even when they are full citizens, these children grow up seeing parents fear doctors and police, absorb messages that the system is dangerous, learn to distrust authority at a formative age. Over time, this can lead to lower academic achievement, higher rates of anxiety and depression, cynicism toward government and law enforcement, alienation from the civic values of participation and community. These children are not illegal, but the shadow of enforcement follows the man will likely influence how they engage with American institutions for the rest of their lives. The surveillance state grows stronger and more invisible. The use of Medicaid records for immigration enforcement is part of a larger trend, the normalization of surveillance. With each agency that adopts data sharing, each database connected across departments, and each exception carved into privacy law, the state becomes more omniscient and the individual becomes more exposed. Today, it's Medicaid. Tomorrow it could be SNAP, food assistance, school lunch programs, public housing, driver's licenses, voter registration database. The infrastructure already exists. What changes is how and why it's used. And if the precedent is set that data equals enforcement, there may be no limits left. Institutional morale and professional disillusionment, doctors, nurses, social workers, case managers, public health officials, these are not ICE agents. They entered their fields to help, not harm. But when their work becomes entangled with surveillance, many burn out. Some leave the profession. Others go silent, afraid to challenge policy. Institutions that once attracted idealists become haunted by compliance mandates. Ethical workers face impossible choices between duty and humanity. The long-term cost is the loss of public service morale and a workforce less willing to speak truth to power. Polarization and the politics of fear. Policies like ICE's access to Medicaid records don't just affect immigrants, they reshape the political landscape. They inflame partisan divides over immigration and welfare, media narratives that pit us versus them, racial tensions as Latino, Asian, African, and Middle Eastern communities are disproportionately surveilled. This drives more extreme politics, empowering lawmakers who use fear to win elections, vigilante groups who see immigrants as threats, citizens who internalize the message that public services are only for the deserving. In time, the social fabric frays not from violence, but from fear institutionalized as policy. 7. The erosion of health, equity, and civil rights. Healthcare in the U.S. is already deeply unequal. Surveillance-based enforcement deepens this divide. Wealthier, whiter populations continue to access care without fear. Immigrants, the poor, and communities of color are pushed into medical invisibility. The civil rights gains of past decades desegregated hospitals, emergency care for all, rights to privacy are quietly rolled back under the guise of law and order. And because it happens in databases, not in marches or riots, the rollback is often invisible to the general public until it's too late. America's global image diminishes. The United States has long promoted itself as a beacon of liberty, opportunity, and human rights. But policies that link public health data to deportation undermine this image. Global NGOs criticize U.S. healthcare ethics. Ali Democracy express concern over data surveillance. Human rights watchdogs cite violations in annual reports. This damages American soft power, complicates international partnerships, and feeds the narrative that the U.S. is abandoning its democratic values. Legal precedents that outlast administrations. Policies often outlive presidents. Even if a future administration issues executive orders to roll back ICE's access to health data, the legal precedents and technological frameworks remain in place. Agencies still have cross-linked databases. Courts may rule that previous data sharing is legal. Future presidents can revive or expand such policies without congressional approval. The long-term risk is the normalization of surveillance as a bipartisan tool, regardless of ideological intentions. A crisis of identity. What kind of country will America become? Ultimately, this is not just a legal or logistical crisis, it is a moral identity crisis. Is the United States a nation where public health is conditional on immigration status? Is citizenship the only metric of humanity? Will future generations inherit a system of care control? The legacy of this policy will be judged not just by deportations completed, but by the families torn apart, children untreated, communities afraid to seek help. This is America's moment of decision. Will it be the nation that uses health care to divide and deport, the one that reclaims care as a universal right? Policy recommendations and future outlook. The surveillance of Medicaid records by ICE is not an unchangeable reality. It is a policy choice, and like all policy choices, it can be reversed, reformed, or replaced. But doing so requires more than moral outrage. It requires clear, actionable policy interventions, political will, and institutional courage across all levels of government. In this section, we outline the most urgent and feasible reforms to restore trust in healthcare systems, protect immigrants from unjust surveillance, reassert legal and ethical standards, build a sustainable, rights-based future for public health in America. Enact a federal firewall law. The most immediate need is a federal law explicitly prohibiting ICE and other immigration enforcement agencies from accessing health data, including Medicaid, without a judicial warrant. Such a law would close the HIPAA loopholes exploited by administrative subpoenas, codify the separation of public health and law enforcement, reinforce the privacy rights of all individuals, regardless of status. Advocates propose a Public Health Confidentiality Act, modeled after the UK's post-NHS scandal reforms, which would bar data sharing without consent, surveillance of patient data without judicial oversight, ICE presence in healthcare settings, unless under criminal investigation. Without such a firewall, all other reforms remain vulnerable. Restrict the use of administrative subpoenas. Congress should reform or repeal provisions in the Immigration and Nationality Act that allow ICE to issue administrative subpoenas without judicial review. This reform would bring immigration enforcement procedures in line with Fourth Amendment standards, prevent unilateral fishing expeditions through public data systems, restore due process protections to individuals whose personal information is being accessed. Any requests for Medicaid or CHIP records should require probable cause, a court-approved subpoena, notification to the individual involved, amend HIPAA for the 21st century. HIPAA, passed in 1996, was not designed for the digital surveillance era. It must be updated to clarify what constitutes law enforcement necessity, limit disclosures to immigration agencies, define minimum necessary in concrete terms, extend protections to state-run public health agencies and Medicaid contractors. Proposed updates could include a HIPAA equity clause ensuring that immigration status alone cannot be used to justify health data disclosures. Pass state-level health data privacy laws. While federal reform may be slow, states can act now. Model policies include California's Health Data Protection Act, New York's Sanctuary Health Zone Ordinances, Oregon's Patient Protection Directive. All states should bar health agencies from cooperating with ICE without a court order, train state employees on rights and resistance to illegal subpoenas, require legal review before any data release, provide funding to immigrant-friendly clinics and mobile units. Even conservative states can find common ground in preventing overreach and abuse of medical systems. Empower healthcare institutions to say no. Hospitals and clinics need clear internal policies and legal guidance to refuse ICE access without a signed warrant. Protect staff from retaliation for upholding privacy standards. Educate patients about their rights. Actionable steps. Display multilingual signs stating, "This is a safe clinic. No ICE without a warrant." Adopt institutional non-cooperation policies similar to sanctuary cities. Create rapid response teams to handle ICE inquiries ethically and legally. Professional organizations like the American Hospital Association, American Nurses Association, and National Association of Social Workers must offer continuing education and legal resources on this front. Fund community outreach and trust rebuilding. Public health cannot function without public trust. Governments should invest in community health ambassadors from immigrant backgrounds, culturally tailored messaging in native languages, know your rights campaigns in clinics, schools, and community centers, safe hotlines for patients to report suspected surveillance. Example, New York City's Health is for Everyone campaign boosted immigrant health enrollment by 17% in neighborhoods previously impacted by ICE presence. Strengthen civil rights enforcement. The Department of Health and Human Services Office for Civil Rights, HHS-OCR, should investigate Medicaid offices that release data to ICE without due process. Enforce anti-discrimination provisions under Title VI of the Civil Rights Act, proactively audit states and contractors for compliance with privacy law. Legal advocacy organizations can file complaints under the Administrative Procedure Act, forcing greater transparency and judicial oversight of data practices. Support litigation against abusive practices. Courts have the power to rein in ICE if challenged. Legal nonprofits and advocacy groups must continue to sue over illegal data sharing, challenge the use of administrative subpoenas in court, demand injunctions on enforcement practices that violate HIPAA or civil rights, represent families harmed by data-driven deportation. Every lawsuit filed, even if unsuccessful, builds legal precedent and public awareness. Build a broad political coalition. This is not only an immigration issue, it is a health issue, a privacy issue, and a constitutional issue. Winning lasting change requires a coalition that includes immigrant rights groups, public health leaders, medical associations, data privacy advocates, libertarians concerned with surveillance overreach, faith-based organizations focused on dignity and family unity. Together, they can frame the issue in ways that transcend partisanship. This isn't about left or right. It's about whether the hospital should be a sanctuary or a trap. Faith leader, Washington, D.C. Embrace a rights-based future. The long-term vision must be one of universal, safe, and dignified access to health care. This means decriminalizing illness, decoupling care from status, redefining public health as inclusive by design, rebuilding the ethical guardrails of American democracy. It also means affirming that data belongs to the person, not to the state, and that accessing care should never cost you your home, your family, or your life. Conclusion of Part 11. Turning the Tide. The road ahead is difficult, but history shows that once Americans understand how a policy harms children, breaks families, and violates core values, change becomes possible, even inevitable. The question is not whether reform is feasible. The question is whether we will act before more damage is done. Conclusion: healing a divided system. There are moments in a nation's life when policy decisions transcend bureaucracy and become moral litmus tests, revealing the kind of society we are and the kind we are becoming. ICE's access to Medicaid records is one such moment. What began as a backdoor tactic to identify deportable immigrants has evolved into a systemic threat that deters families from seeking life-saving care, endangers children, pregnant women, and the chronically ill, undermines decades of public health progress, violates medical ethics and constitutional protections, damages public trust, and erodes social cohesion. This is not a hypothetical concern. It is happening quietly, daily, relentlessly in clinics, homes, and emergency rooms across the country. And its victims are often the most vulnerable, those with the least voice, the fewest options, and the greatest need. A nation at a crossroads. As we've explored, this crisis did not emerge from a vacuum. It stems from a convergence of decades of punitive immigration law, weak privacy protections, fragmented healthcare systems, political fear-mongering, institutional inertia. Together, these forces have turned public benefit programs into surveillance tools, punishing people for daring to seek care. This weaponization of compassion is not only unethical, it is unsustainable. America now stands at a crossroads. We must decide, will we protect the sanctity of the doctor-patient relationship? Will we defend children's right to access health care without fear? Will we resist the expansion of data-driven enforcement into every corner of civic life? Will we uphold the values of justice, dignity, and due process? Why this fight matters for everyone. While this issue most immediately affects immigrants, it ultimately impacts everyone. If your health data can be accessed without a warrant for immigration enforcement, what's to stop similar tactics for tax audits, protest activity, or voter registration? If Medicaid data can be turned against families, what about public school records, SNAP applications, or housing forms? If we normalize fear in the waiting room, how long before fear becomes the default across all public services? This is about who controls data, who defines security, and who is deemed worthy of protection. A call to action. The solution is not just to criticize the current system, but to build a better one. That means advocating for legislation that draws bright lines between care and enforcement, empowering local and state leaders to resist unjust data sharing, supporting legal action that reasserts constitutional boundaries, funding outreach to rebuild immigrant trust, voting for candidates who defend human dignity, regardless of status, and it means never accepting the false choice between compassion and control, between security and humanity, restoring America's moral compass. In the end, this is not a debate about documents or data. It is about human beings, neighbors, classmates, co-workers, parents, and children. It is about a mother deciding whether to treat her cancer or hide, a father choosing between dialysis and deportation, a child going unvaccinated because her parents are afraid. These are not policy dilemmas. These are ethical emergencies. We must ask ourselves, what kind of country do we want to be? A nation where hospitals heal, not betray, where health care is a sanctuary, not a snare, where children are protected, not penalized? The answers will define not only our immigration system, but the soul of American democracy itself. Final words. Compassion is not a loophole. Let us be clear. Seeking medical care is not a crime. Loving your child is not a crime. Surviving is not a crime. And compassion is not a loophole. It is a principle, a value, a legacy worth defending. If we lose that, we lose far more than control. We lose our very identity.